In the last video, we learned about the pathophysiology of ASOM. So today we'll be seeing about the management of ASOM. As I said in the previous video, the diagnosis is mostly clinical. A proper history and a clinical examination will lead you to the diagnosis. You need not require to do any investigations before you start treatment. But if you are suspecting any complications, you can do an imaging of the temporal bone, an HRCT temporal bone, or an audiogram. Or if you are suspecting any sepsis, you can do a complete blood count and further evaluation. So the treatment is mainly treatment of the disease and also alleviate the ear pain. So you can start with antibiotics. Antibiotics has to be started if there is ear pain and fever and a congested tympanic membrane. Always start with a baseline antibiotic. So the antibiotic of choice is usually amoxicillin or amoxicillin clavulanate. You can also give cephalosporins and also macrolides like erythromycin, azithromycin is effective. So start with the baseline antibiotic and then shift to a higher antibiotic if it is not recovering. Do not start with a fluoroquinolone or a higher antibiotic in the first step itself. Then you can give nasal decongestant drops to open up the eustachian tube. You can give cyclometazoline or oxymetazoline. You can also give systemic decongestant or systemic anti-allergens. You can give phenylephrine antihistamines. Can also be given as supportive treatment. Analgesics. You always follow the WHO pain ladder. Start with the basic analgesic. Start with the paracetamol. And if the pain is not improving, you can add on an ibuprofen or an NSAID at a second step to start with paracetamol. In some cases, some refractory cases, you will have to do a procedure known as Myringotomy. So what is Myringotomy? A surgical incision is made on the tympanic membrane. So the tympanic membrane is opened and the pus is drained. It is same as in general surgery. An IND is done when a pus is cultured in a place. You do an IND and remove the pus. Similarly, 3 to 5 mm incision is made on the tympanic membrane using a myringotome and the pus is drained. So in ASOM, myringotomy is done if it is a severe ASOM with severe ear pain, bulging tympanic membrane, and if there is suspected impending complications like a facial palsy, mastocytitis, meningitis, etc. Another indication in ASOM is recurrent episodes of ASOM. More than 3 episodes in the last 6 months or more than 4 episodes in the last 12 months. In infants and children, it is done under general anesthesia. In adults, it can be done under local anesthesia also. So, in an ASOM, the incision is made in the postero-inferior quadrant. A circumferential incision is made on the tympanic membrane and the pus is drained. Another indication for myringotomy is serous otitis media. So, in serous otitis media or glue ear, it is not purulent. So the fluid is continuously accumulating in the middle ear due to a eustachian tube dysfunction. In such conditions, we do a myringotomy and place a ventilation tube or grommet at the incision site so that the fluid is drained continuously. So in serous otitis media, the myringotomy incision is made in the antero-inferior quadrant and a radial incision is made. Why this difference? You know that the fibrous layer of the tympanic membrane contains mostly radial fibers. In ASOM, we use a curvilinear incision because the curvilinear incision will separate the radial fibers and the incision will be patent for a few days and the pus can drain effectively. For ASOM, we use a radial incision in the antero-inferior quadrant because radial incision, once we put the radial incision and insert the grommet inside, the radial fibers come together and keeps the grommet in place. So that is one reason why we use a radial incision in the antero-inferior quadrant in serous otitis media. Also, radial incision helps to heal the tympanic membrane without much scarring. So that is preferred in serous otitis media. In ASOM, we use a curvilinear incision, postero-inferior quadrant. ASOM, we use a radial incision, antero-inferior. There are different types of grommet available. So you can use the grommet which is required according to the availability and necessity. There are grommets called as T-tubes which is used in ASOM for prolonged ventilation. After the myringotomy, the patient has to be given a basic course of antibiotics. Also, after the myringotomy, the water should not enter into the ears. If swimming and all those activities are not allowed for such patients. Complications of myringotomy. Injury to the middle ear structures like IS joint. Also, if the patient is having a high jugular bulb, you can injure the jugular bulb causing bleeding. Then another complication is because the ventilation tube is there is a patent opening from the external auditory canal to the middle ear. And if the patient is not careful, the patient can get recurrent medullary infections. Sometimes the myringotomy will not heal properly, leaving a permanent perforation in the eardrum. It can cause scarring and tympanosclerosis of the tympanic membrane. We'll be dealing with the complications of otitis media one by one in the upcoming videos.